Okay, so hello everyone. I hope I'm visible and audible clearly. So I'll start with today's session. I am Sharmishta Majumdar, a PhD scholar from IIT Jodhpur, and I am your PMRF TA for the course Maternal Infant Young Child Nutrition, which is being taken by sorry, yeah, which is being taken by Dr. Rupal Dalal from IIT Bombay. So, as we all know that this course is of a unique nature. And before I start with any discussion sessions, I would like to understand who the learners are actually, what are their backgrounds. So, yeah. So, do we have undergraduates, postgraduates, working healthcare professionals? So, I would request at least some of you to jot down in the chat boxes regarding your backgrounds so that it is helpful for me to plan my subsequent sessions accordingly. Slide is visible. Okay, thank you. Okay, so today I'll be going through the weeks 1 and 2 with all of you. So I hope as of now you have. I'm sorry for the to join. Yeah. Okay, are my slides changing? Okay, thank you. So, yeah, thank you. So, as I just said, we'll be going through the weeks 01 and 02 with all of you. So, as I can see, a lot of you are already, informed about the things that we will be going through here. I will be specifically focusing on some questions in these discussion sessions. But obviously, for the first 2 weeks, we'll be going through some basic concepts that we obviously require whenever we are considering maternal and child healthcare, infant healthcare. And then I'll be discussing some specific model questions, which will obviously be helping you people to take your further assignments. So, before moving on to the specific question answers, I would like to ask you people that the image and the three words that you can see on the slide, can anybody please tell me what correlation or what significance do you see between these? Would anybody like to volunteer? Anybody? I hope my slide is visible, right? Yeah. So, uh, o- okay. Okay. Yeah, I think now it's visible. Okay, so if I tell that among these three children, one is obviously the reference or the normal child, and the rest are a combination of these two parameters. So, can anybody tell me what each child signifies in these images? Yeah, you have very correctly said. But here, if we consider the first child to be normal, then of course our second child is underweight and wasted, and our third child is underweight and has stunted growth. So, whenever we need to understand the important nutrition parameters in children, we have to be very clear about these three terminologies. I think everybody sent it. Yeah. Yes. So, whenever we talk about malnutrition, so we are dealing with something on both the extremes of the spectrum. So, on one end we have the underweight, and on other end we have the overweight. In this case, we will be talking more about the underweight cases, where we have some underweight children, some wasted children, and some stunted children. So obviously, for all the students in this course who are, apart from the people who are already well informed about these terminologies, but apart from them who are just going through the basic of this child and maternal nutrition, I would suggest them that these three concepts, these are very important to know about the clinical aspect of the patient. So now with this concept, I would go to my first question. So the first question is, as per NFHS 4 data, how many children under 2 months of age in India are acutely malnourished or too thin or wasted? So first of all, can anybody please tell me what is the full form of NFHS? Yes. So National Family Health Survey. So this is a very important survey which is being done by the Ministry of Health and Family Welfare. Yeah. So as we know that this survey was first done in 1992 to 93, and then after that, okay, yeah. And then after that, the two data sets that you people have been reading about in your lectures in week 1, the data sets that we have been studying, these are the NFHS 4 and the NFHS 5, right? So NFHS 4 is the survey that has been done in the year 2015 to 2016. And of course, the latest data set or the most recent one is the NFHS 5. So can anybody tell me the answer to this question? Can anybody guess the answer to this question? According to the NFH, yes, A option would be right. So let us, okay, yeah. So A option would be right. And let us go through the NFHS 4 statistics. So if we consider the first panel where we can see the 0 to 2 months of data, where the blue bar, it signifies the stunted growth, the yellow bar signifies the underweight, and the red bar, it denotes the wasted percentage population of children. So as we can see that the red bar is at 34.3%. So obviously these statistics are very important. Yeah. Yeah, so continuing, sorry for the interruption. So these statistics are very important if we want to monitor the status of our, yeah. So as we can see that the percentage of children under 2 months of age in India who are wasted or too thin or acutely malnourished are there, therefore 34.30%. Now going to my next question. So as per the same data set, how many children are born stunted or short at birth? How much is the percentage, do you think? It is a little less than one third. Specifically, it is 20%. So as you can see, I'm really sorry for the interruption. Yeah. So as we can see from the same statistics, we have 19.7% of stunted cases of children in the 0 to 2 months of age group. So approximately it is around 20. Yeah. So according to the NFHS 4, which is the data set in around 2015 to 2016. So these are the statistics. Now we have the NFHS 5, which has got a more upgraded set of data. So let's see. So we have seen the NFHS 4 data, and on the right side we can see the NFHS 5 data. So if we consider the 0 to 2 months panel of both NFHS 4 and NFHS 5, we can see that there has been a definite decrease of the wasted cases. So initially in NFHS 4 data, we can see that the wasted cases are around 34.3. But in NFHS 5, we can see that the wasted cases are definitely less than 30%. But again, contrary to the wasted cases, we can see that there has been a considerable increase in the stunted cases. So as we have seen that in the NFHS 4, 19.75% of cases are stunted cases. But again, in the NFHS 5, there has been an increase. So as we can see, it is almost near to 30%. So these things are very important to take into consideration, that what are the changes occurring with time, specifically Yeah. So these statistics are very important when we are considering the all throughout changes that we are seeing in a country like ours. So the next question would be, as per the NFHS 5 data, what is the exclusive breastfeeding rate in India? So before going on to the answer of this question, I would like to discuss something which is very important for infant survival. So number one is the early initiation breastfeeding. So as we all know that whenever a child is born, the mother So we know that whenever the child is born, the mother is advised to breastfeed the child within the first hour of birth, right? So this is known as the early initiation breastfeeding, and this is very crucial for the survival of the child. And then with the early initiation breastfeeding, after that, the child is supposed to, or the mother is advised to breastfeed the child at least till the 6 months of age. So that is called an exclusive breastfeeding period. So after birth, so after birth, within 1 hour, the child, I'm really sorry for the constant interruption. So So then we have the exclusive breastfeeding, which is for the next 6 months. And then from 6 to 8 months, the mother is advised to give something which is called a complementary feeding to the child. So at this point of time, it is not only the breast milk which is required for the overall nutrition of the child, but along with the breast milk, these are some other complementary food which is required for the overall nutritional enhancement of the child. So here, if we concentrate on the statistics, as we can see, India here, as we can see on the left panel, if we check at the last, we can see that in India, it is around more than 60%. So in our options, we have 50%, 62%, 43% and 39%. So it is around 62% of cases in India which are of exclusive breastfeeding. So the exclusive breastfeeding rate in this case in India is 62%. Again, we can see that if we consider the status of the states, so Sikkim has the lowest exclusive breastfeeding rate, which is around 25%. And on the contrary, Chhattisgarh has the highest exclusive breastfeeding rate amongst all the states in India, which is about 80%. So these extremes of our statistics need to be remembered very clearly, because these are which is important to be followed. Then, as I come to the early initiation breastfeeding statistics, we can see that India is at around 41 to 42%. And among the states, Jharkhand has the lowest early initiation breastfeeding statistics, with Meghalaya having the highest, which is around 80%. Then again, if we move on to the complementary feeding statistics, we can see, so if we move to the complementary feeding statistics, we can see that Uttar Pradesh has the lowest complementary feeding statistics here. And Manipur has the highest complementary feeding statistics. So, which is around 80%. And an overall 45 to 46% of 46% of complementary feeding accounts for the whole of India. So next, if we consider this question, as per NFHS 5 data, which state has the lowest rate of initiation of complementary feeding between 6 to 8 months? So as we have just seen, complementary feeding statistics, the lowest is Uttar Pradesh. So complementary feeding, the lowest is Uttar Pradesh, which is around 40%. So then the answer for this question comes to Uttar Pradesh. So as we can see that whenever we are checking the introduction of complementary foods in children in 6 to 8 month statistics, we can again see that there is no state in India which is less than 20%, and mostly lie in the range of 20 to 39.9% and 40 to 59.9%. So in this case, as we have seen in the NFHS 5 statistics, so Uttar Pradesh has the lowest rate of initiation of complementary feeding. So I understand that these statistics might be a bit boring, and they might not be really interesting, but whenever we consider the patients, or whenever we consider the overall scenario with the maternal and child health, so this cumulative picture of India is very significant, because that is how all the states, they come up with a proper picture as to how the state of nutrition for our mothers and our children, they are improving in our country. So next, so for the next question, so next question is, as per NFHS 5 data, so as I have told already that NFHS 5 is the most recent one, so which is from 2019 to 2021, and it is usually in a gap of 3 years, and we can also expect the NFHS 6 also to come very soon. But as of now, let us focus on the NFHS 5 data. So according to this question, the question states that which state of India has the lowest percentage of anemic children? So up till now, what we were seeing is the percentage of undernutrition or percentage of underweight children. And then we came to the statistics which were giving us a picture of, number one, the early initiation breastfeeding, which is very important for the survival of the child. Next, the complementary, the exclusive breastfeeding for the maintenance, and number 3, the complementary breastfeeding. That is, after the 6 months of age, what are the specific important nutritional factors that the child definitely requires other than the mother's milk. Right. So now we come on to a different parameter here of statistics, which is anemia. So as we all know that anemia can be of different types. It can be iron deficiency anemia, megaloblastic anemia, pernicious anemia, etc. So here, what the NFHS 5 data has also shown us, it has given us specific data as to which state has the highest and the lowest percentages of anemic children, because we all know that anemia is also directly related to the status of nutrition. So if we consider the anemia, the incidence of anemia in children between 6 to 59 months of age, right? So 6 months to around 5 years of age. So we can see that in India, it is around 65%. So it is really very difficult to grasp this information that 65% of our children in India in between 6 months to 5 years of age, they are actually anemic. So if they are anemic, and then we can actually think about the nutritional status of these children as well. So now if we go to the state-wise distribution of the anemic status, we can see that Ladakh has the highest. It is more than 80%. So Ladakh has the highest percentage of anemic children between 6 to 59 months of age. So shockingly, it is more than 80%. So as per the question, we can see we have the options Ladakh, Haryana, Kerala and Gujarat. So they have asked us the lowest percentage, which we can say it is around 40%, and the state which has the lowest anemic situation according to the NFHS 5 data is Kerala. In spite of having the lowest percentage, but we can't still say that it is at a safe side, because the lowest percentage is also around 40%, which falls in the red zone. So we have to be very cautious regarding these nutritional indicators, the parameters on which these data have been taken, and we can see that in spite of figuring so many different nutritional indicators, we can still see that between NFHS 5 and between NFHS 4 and NFHS 5, there are still some parameters which need to be taken care of, right? So to the next question, which of the following is a cause of stunting in babies? So as we already know that stunting means shortened height, a baby who's a child who is shorter than what is expected of his or her age. So can anybody tell me the answer to this question? Yes, ineffective breastfeeding practices. So as we have just we have discussed about the different breastfeeding categories: the initiation of breastfeeding, the exclusive breastfeeding, and the complementary breastfeeding. So all of them together, they are very much important for the overall nutritional status maintenance of the child. So as we can see in the different options, so number one is exclusive breastfeeding for the first 6 months. So if the child gets exclusive breastfeeding for the first 6 months, nothing like that. It is the ideal, it is the optimal situation for the child. But our question says, which is the cause of stunting? So the stunting is definitely an indicator of undernutrition. So obviously our option A gets eliminated. So option B, feeding colostrum milk within the first hour of birth. Again, this is the ideal and the most desired thing that we would want, where the child is being given the first milk after birth, within the first hour of birth, right? So options A, B and C, we can say that these are the desired situations. So very rightly said, ineffective breastfeeding practices, amongst these options, it is the cause of stunting in babies. And so it is imperative to let the mothers of our country know about the different breastfeeding practices. We know that many people know that, okay, they have to breastfeed their child, but in spite of breastfeeding their children, it has been seen that maybe the child is not developing that proper nutrition. So there lies the catch. Breastfeeding techniques. So those specific breastfeeding techniques, these practices, they also need to be inculcated into the Indian population, the Indian maternal population. So we'll definitely be learning about these breastfeeding techniques in the course of this, in the later sessions of this course. So, to the next question, what is the most common cause of exclusively breastfed babies not gaining weight? So, this is also, I think this will be very easy for all of you. If somebody could just tell me the answer. A, right. So, of course, as I just discussed, uh, the knowledge about breastfeeding techniques and the breastfeeding skills, it is very important and it is indispensable to know about it. So, of course, the answer to this question is due to inadequate knowledge about breastfeeding skills in mothers and healthcare workers. Okay, first three questions. Okay. Yeah, so the first three questions, they are based on the NFHS 4 data only, right? NFHS 4 and NFHS 5 data. So these are based on the different nutritional status of children and also the breastfeeding rates. So if you go through the NFHS 4 and NFHS 5 data sets, I think it would be quite easy for you to answer those kinds of questions also. So it shouldn't be a problem, even if you have missed the specific questions now. I think it would be fine. Yeah, so whatever sessions are being taken, so these will be recorded and the recorded versions will be made available to all of you. Uh, Next, I'll move on to question number 8. So, in NFHS 4 data, stunting increased from 19.11% in under 6-month-old babies to 24.8% in 7 to 12-month-old babies. So, here we are dealing with a situation where there has been an increase in stunting, which obviously it is not desired. But what do you think could be the reason for this? Can anybody else guess the answer? Right. So this is quite simple to understand. So all that we need to remember that the complementary feeding has to be given to the child after the 6 months of age, because that is how the child's exact nutritional status will be maintained, because after the 6 months of age the body requires something which is more than that of the mother's milk. So obviously the complementary feeding needs to be there, and in this case, as we can see, that it increased from 19% and to 24%. So there has been a massive increase of 5% in the 7 to 12 month old babies. So this happened obviously because of the complementary feeding issue not being catered. So now I move on to the next question. So, if the babies in the US are growing well with formula feeding, what's the risk in using formula for babies all over the world? So, I wouldn't really like to think about all over the world. Many of us here, we are healthcare professionals. Let us just focus on India. So, what do you think is the problem with formula feeding and babies in our country? So of course, from the MCQ options, it is really easy to just chalk out the answer. But what do you think? Like, if you have to discuss on this matter, what are your views? Anybody would like to volunteer? Right. 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 Yes, correct. Absolutely. The answer is point number A. It is related to that only. So, what do you think that even after so much of campaigning, uh, I mean, what are your views on this uh, campaigning of these formula feeds? Like, if I ask people who are from the healthcare sector only, so what are your opinions on this? Definitely, it is causing some allergies, and research has shown that the children who are fed with formula milk or who are formula fed, they have higher chances of being overweight. So, obesity and overweight, obviously, these are the issues. And what could be other problems that children in India can face? Keeping in mind the overall scenario of India, the socio-economic and the health scenario in India. Okay. Okay. Yes. Yes, of course. And when we also consider the socio-economic strata of our country, we have very rich people, we have very poor people. So, not talking about people in the between, but whenever very poor people are trying to feed their kids with formula milk or formula feed, so obviously this dilution factor and all of the points that you people have mentioned, it comes into the question. So, thank you for your responses. So, just going back to the question, of course, it increases the risk of allergies, asthma, diarrhea, obesity, etc. So, that is where the difference between a developed country and a developing country comes into the picture, unfortunately. Yes. So, going on to the next question. Um, why do some malnourished children don't recover completely even after giving them the prescribed treatments for malnutrition? Uh, Miss Kaushalya, can you please mute yourself? Yeah, thank you. Yes, bullet D is the correct answer. So, if we consider the answers to these questions, like I have said already, like they appear very easy from an MCQ perspective. But when we think of it from the grassroots level and the actual situation, so these things are very important when we go into the clinical scenario. So, hence, if we see, sorry, so there are some children who don't recover completely even after the specific prescribed medications are given to them. So let us just follow the options first. The treatment is not right. Obviously, it doesn't make sense. They need more exercise. No. They need more calories. No. So as we have repeatedly established the importance of breastfeeding and the importance of the proper complementary food that needs to be given to the child, so of course these children, they have been chronically malnourished, so they were not given a proper breastfeeding and they were not given a proper complementary food regime from the time that they were supposed to be given. So that is the reason why, in spite of giving loads and loads of treatment to these children, they still stay malnourished. So moving on to the next question. uh, can low birth weight babies grow properly with effective breastfeeding? Can somebody answer? Yes, yes, definitely yes. And you must have come across beautiful examples of the clinical cases that Dr. Dalal has shown in her recorded videos, where she has shown images of babies who were underweight at birth, but after the mother breastfeeding them properly and effectively for the first few months, uh, the babies have grown very beautifully. So that is one very significant factor here that needs to be kept in mind, which is effective breastfeeding. So in spite of emphasizing on the factor so many times, it is still indispensable if I still don't say that it is only effective breastfeeding that can actually bring about a very significant change in the overall nutritional maintenance status of the child. So, of course, from the MCQ point of view, it is possible. So, the low birth weight babies can definitely they grow properly if there is effective breastfeeding. Okay. So, next, question number 12. What can mask severe acute malnourishment or very low weight for height in children? So, anybody would like to volunteer? Yes, stunting, right. So, when we are saying very low weight for height, so what do we mean here? Very low weight for height. No, very low weight for height. If we consider this terminology, wasting, correct. So we have just read about, we can just recapitulate regarding the underweight, the stunting, and the wasting. So obviously what happens, so when there is a child with very low weight for height and there is wasting, the child automatically looks short, and this situation can again be masked if there is stunting in that child. So stunting is definitely shorter for age. The child is shorter than what he was supposed to be at that age. So of course stunting is another nutritional malnourishment indicator which has the potential of masking acute malnourishment and very low weight for height or wasting in children. So of course whenever clinically we come across some patients like this, it becomes very imperative to distinguish at which clinical state the child is in. Miss Prema, can you please mute yourself, or you can go ahead if you have any question. Okay. So as we have discussed, so definitely it is stunting which can mask the severe acute malnourishment or again the wasting in this case in children. Again, high lean mass, of course, high lean mass is a desirable property which we want to see in children, because the high lean mass is the total weight of the child minus the fat which is there, the weight of the fat. So of course it is a good thing, it is a good health indicator that it is that is desirable. Proper complementary feeding, obviously proper complementary feeding is there, it is also a desirable factor that wouldn't really lead to malnourishment, and of course proper breastfeeding is also desirable. So next, what would a just delivered mother do to pass on infection fighting elements? So of course what we are talking about is immunity, good fat and nutrients to a newborn baby. So I think all of us, we already know the answer to this question, but still I would like somebody to volunteer. Yes, colostrum. So as we all know that the first yellowish milk which comes immediately after the child parturition and stays there for around 2 to 5 days is called colostrum, and it has got high nutritional value. And of course the mother is always advised to feed the child the colostrum. So, and can anybody just let me know which immunoglobulin is present in colostrum? Yes. So IgA, IgM, IgG, Yes. So Ig, as I was saying, IgA, IgG, IgM, all of them are present in colostrum, but it is IgG which is predominantly present in colostrum that gives the majority of the immunity to the baby. So here, definitely, if we consider the options, we'll obviously not give formula milk to the child who has just been born. Honey in formula milk, also no. Though I have heard about a lot of people who give honey to a newborn baby. If anybody has any opinions on that, they can definitely share. But obviously, we won't be giving honey in formula milk or honey in animal milk to a newborn baby. So the best option for a newborn baby is the first milk or the colostrum. So next, moving on to number 14. So which one of these is not a source of complementary food for children? Can anybody let me know the answer? Yes, absolutely correct. So whenever we are talking about complementary food, we are talking about something that is adding to the breastfed milk to the child, the requirements of the child after a period of 6 or 8 months of age. So that is when the different groups of food comes into play. So there are a lot of people who start giving plain water, more of plain water to the child, or non-milk liquids, or milk from other sources, bovine milk or other sources, and also they start giving some other complementary food. So colostrum is one of the options here, which is definitely can never be a complementary food because it is the numero uno requisite for a baby. So as we have just discussed in the last question, whenever the baby is born, so the first milk or the colostrum is the most ideal and the most significant piece of nutrition that needs to be given to the baby. So moving on to the next question. So we have what are some nutrients from the food that cannot be produced by our body called? Anybody with the answer? Yes, absolutely. So essential nutrients, now let us see in this image. So we can see there are carbohydrates, fats, proteins, vitamins, water, and minerals, right? So whenever we are talking about the essential nutrients, these 5 nutrients are the most significant nutrients that are indispensable for our body. We need them, but these are some things which cannot be produced innately from our body. And so it is also very important to get this in our diet. And that is where the concept of balanced diet comes into the picture, where we have specific ratios of how we should take in carbohydrates, fats, and proteins, along with the minerals, vitamins, and of course, intake of water. Next, I will come to the different topics that have been discussed in week 2 also. So here we'll be discussing about the different nutrients and the different nutritional deficiencies that happen in children. So here, let us come to the question. So the way to diagnose any nutrient deficiency is to measure and track the weight, height, and mid-upper arm circumference. Okay, so does anybody know the answer, or can anybody just tell me what is type 1 nutrient deficiency and what is type 2 nutrient deficiency? The answer is there. Just let us have a discussion. Will anybody? Yes, absolutely correct. So type 1 is definitely functional nutrients. So these are important for giving the functions to the different components of the body or the tissues. And type 2 is required for the overall growth, and it starts from the first part of the growth of the child. So now if I come to the question, nutrient deficiency that can be measured and tracked with the weight, height, and mid upper arm circumference. So we are coming into something called as anthropometrics, right? So whenever we consider something as weight, height, mid upper arm circumference, so what are we looking at here? Type 2. Exactly. So, what we are trying to consider here is the growth of the child. So, if the growth of the child has been compromised, so that comes under the type 2 nutrient deficiency. And that is how, with the help of different anthropometric measurements, we can get to know whether the child is suffering from a type 1 nutritional deficiency or a type 2 nutritional deficiency. Okay. So, coming to the next question. Supplements are commonly recommended to correct what kind of nutrient deficiency? Again, it's a question with an easy answer. So I would like you type 1. Yes. Type 1. Correct. So as we just discussed, so type 1 is functional nutrients. So functional nutrients, they do not have an immediate effect. It is not like if I stop eating those functional nutrients, my body will immediately show something. But here we are talking about babies, right? So in babies also, it will not definitely show an immediate effect as in case of the deficiency of growth nutrients, that is type 2. So in type 2 nutrient deficiency, there will be a definite growth deficiency, which is more important in case of children. But again, in type 1 nutrient deficiencies, it is something which is reversible that can be solved with the use of supplements. So, of course, the supplements are recommended to correct type 1 nutrient deficiencies. Yes. So, next question. What kind of foods, even in large amounts, can satisfy only the feeling of hunger? Yeah, this is also a question with very easy. All of them. Yes, it is nutrient poor foods. So, obviously, if the food that we are feeding our child, or the food that any person is feeding on, if that has got zero nutritional value, so that can definitely never satiate the person. So it can only satisfy the feeling of hunger, that okay, my brain says that I am feeling hungry, so I just keep on gorging on something, which is of course not giving me the specific nutrient that my body requires or demands. So that is nutrient poor foods. So coming to the next question, in a type 1 nutrient deficiency, is the appetite affected? So as we just studied about the type 1 nutrient deficiency and the type 2 nutrient deficiency. So what do you think the appetite is like in both these nutritional deficiency? Sorry? Why do you think appetite reduces in type 1? Okay. Yes, so if somebody is telling appetite reduces, why do you think it reduces? And if somebody is telling appetite is not affected, why do you think it is not affected? Because we are talking about type 1 nutrient deficiency, right? So if it is type 1, what do you think? Affected or not affected? Okay. Okay, so let's come to the correct answer. In type 1 nutrient deficiency, it has been seen that the appetite in the children is usually not affected. And what reduces is usually in the type 2 nutrient deficiency, which are the growth nutrients. So, of course, if we are considering type 1, the appetite is not affected, right? Okay, so next, which is not a type 1 nutritional deficiency? Okay, before moving on to this question, I would like to say that, of course, we have come to know about the type 1 nutritional deficiency and the type 2 nutritional deficiency, right? So, which one do you think would show more of clinical signs um, when you consider a child reporting to an OPD or anywhere? Like, which one do you think would show us more clinical signs? Is it type 1 or type 2? Yes. So, the person who's saying type 1 with clinical features, can you explain why do you think so? Correct. Absolutely correct. So, here, when we talk about the clinical manifestations, yeah. So, when we are talking about the clinical manifestations, so they will be more prevalent in the type 1 nutritional deficiency. So, type 1 nutritional deficiency we just studied. So, these are the 5 major groups. So, 5 major groups. So, there, if we talk about the type 1 nutritional deficiency, so coming back to the question, what would you think is not a type 1 nutritional deficiency amongst the options? Yes, yes, magnesium deficiency, correct. So the answer is absolutely correct. Again, as we have just discussed, type 1 nutritional deficiency, the clinical manifestations are more predominant, right? So it is easy to diagnose a child with type 1 nutritional deficiency. So we have all known, okay, this child has iron deficiency. Most commonly, we know iodine deficiency. This child has iodine deficiency, riboflavin, all the vitamin B deficiency, and all of it. But it is difficult when we consider potassium, magnesium, sulfur, phosphorus, zinc, these kind of deficiencies. So these are more difficult to diagnose and hence treat at a later stage when these type 2 nutritional deficiencies are considered. So obviously, whenever we are considering a type 1 nutritional deficiency, so the clinical manifestations are there. So something which we can see, we can think of treating, but something which is difficult to see, so that is difficult to treat. So definitely here magnesium deficiency is the answer to this question. So for today's discussion session, these were the sets of questions that I wanted to discuss with